Thanks for joining us for today's webinar. Today marks the beginning of National Heart Month, and as part University Hospital's Harrington Heart and Vascular Institute is proud to be in its 14th year as the local presenting sponsor of American Heart Association's Go Red for Women campaign. Today's webinar focuses on the topic of stroke prevention in patients with atrial fibrillation, the most common heart rhythm disorder. A couple housekeeping notes before we begin. All attendees are muted. While you won't be able to ask questions through audio, please submit any questions you have through the Q&A box on your screen, and our speakers will answer as many as possible after the presentation. Also, today's webinar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link once it's live. It's now my pleasure to introduce our speakers. Dr. Mauricio Arruda is a cardiac electrophysiologist and director of the Electrophysiology Center and Atrial Fibrillation Center at University Hospital's Harrington Heart and Vascular Institute. He holds the John R. Antonucci Master Clinician of Cardiovascular Innovation and is an associate professor at Case Western Reserve University School of Medicine. Co-presenting with him today is Dr. Stephen Philby, an interventional cardiologist at University Hospital's Harrington Heart and Vascular Institute and director of our cardiac catheterization lab at University Hospital's Cleveland Medical Center. He is also an assistant professor at Case Western Reserve University School of Medicine. Welcome to our speakers. I'll turn it over now to Dr. Arruda to kick off today's presentation.
Good afternoon. Welcome to our webinar. This is an extremely important topic. We'll be discussing the management of atrial fibrillation at university hospitals with a particular focus on stroke prevention. So let's start by asking ourselves, what's atrial fibrillation? So atrial fibrillation is a disorder of the electrical disorder of the heart, particularly with the heart rhythm. It's also known as AFib or AF. It's the most common heart rhythm abnormality. It accounts for 15 to 30% of all strokes and results of a very frequent hospitalizations and office visits for management of this rhythm abnormality. It also accounts for about 30 to 40% of development of heart failure in our population. And in addition, up to 5-fold increased risk of memory impairment, including various types of dementia. So first, we will, excuse me for a second, I'm not so dry. First, we start by looking at the heart rhythm. What's the normal heart rhythm? You see the chambers of the heart here, the left ventricle, right ventricle, and the upper chambers responsible for atrial fibrillation, the right atrium, left atrium. The heart, before every heart beats, there is an electrical impulse. It's starting at the sinus node, and the electrical activation is spread throughout both atria. And that generates on EKG a little wave called P wave. Then, since the heart valves are insulation of electricity, the electrical impulse enters the special filter that we have in our hearts, then is spread to two electrical wires, if you will, the bundle branches, and then activate the bottom chambers, the pumping chambers, ventricle, inscribing a wave on the EKG as well. And here you see a sequence of a normal heartbeat on the ECG. So as I just described, every heartbeat starts from up there, comes to the filter and spread to the ventricle and gives you a very regular rhythm. On the other hand, when we are in atrial fibrillation, the upper chambers of the heart are quivering, is having very multiple little wavelets of electricity spreading to both chambers and becomes very ineffective. So during this slow flow of blood, there is a good chance, if you're not protected, that the blood can form clots in particular areas of the atrium, leading to a stroke. So here you see that the rhythm in atrial fibrillation are very erratic. There is no regularity, and every heartbeat has a different interval, which becomes very ineffective. One thing that also known in atrial fibrillation is patients develop scar tissue. Look at the normal heart. If you take a piece of muscle from the atrium in normal individuals, you see just the red normal heart muscle. While patients with the atrial fibrillation, they may have already developed various degrees of scar tissue, seen in blue here within the heart muscle. So what are the associated disorders, associated comorbidities that patients could have to atrial fibrillation? The most common are related to the cardiovascular system, the heart and blood vessels. Commonly hypertension, high blood pressure, but also vascular disease, valvular disease, heart failure, blockages of the coronary arteries, dilated hearts, being born with the heart defect, and problems with the outlining of the heart, the pericardium, but also seeing patients with comorbidities outside of the cardiovascular system, such as COPD, abnormality in thyroid hormones as hyperthyroidism, diabetes, excessive use of alcohol, and in patients that post heart surgeries. In terms of symptoms, a lot of the patients, at least half of the patients, present with some sort of a palpitations, erratic heartbeats, feeling on the chest, fluttering. But the most common, we see patients with some degree of shortness of breath, particularly during exercise, and fatigue that you can't explain. There's going to be also a smaller group of patients that present with chest pain or discomfort. Others may even pass out during atrial fibrillation or develop serious dizziness. However, about 10% of our patients present without any symptoms whatsoever. The AFib are classified by paroxysmal, persistent, or permanent. This is also related with the progression of this electrical disease process of the heart. The early stage of paroxysmal is patients with AFib self-resolving within a week. Patients might be in and out of AFib. Persistent atrial fibrillation is AFib that lasts over a week, or it needs to be interrupted because patients are not feeling well and lasts a week with an electrical cardioversion. And once there is no means to be able to recover normal rhythm, we label the atrial fibrillation as permanent. Unfortunately, it is a very prevalent problem. As you see here, there is an estimation that by 2050, almost 16 million of people will be having atrial fibrillation. So once a patient is first diagnosed with atrial fibrillation, our first thought process is to look into if there's any existing comorbidities to this patient that we can address at the same time as we manage the rhythm itself. We look for situations as obesity, sleep apnea, physical inactivity as hypertension, diabetes, alcohol, as I mentioned before, smoking, coronary artery disease, and heart failure. So this is, we start in parallel managing these conditions if they exist. And no patients leave the office after the first encounter until they are assessed if they need stroke prevention. The first thought process is blood thinners, but you'll hear much more about this particular aspect of the management later with Dr. Philby. Next, we look at the rhythm itself. If the heart rate is too fast, we have medications to help patients to slow it down. And also medications to control the rhythm itself, even though not very high efficacy, but will help us to control a subset of patients with AFib. So looking at these traces here from the body surface, we see the waves and erratic rhythm rates here, a patient with atrial fibrillation. When we put catheters inside of the heart in atrial fibrillation, you can see there is a true electrical storm, in both upper chambers of the heart. As you see, as a consequence of this irregularity, some patients develop thinning of the pumping chambers of the heart and progression to heart failure. In comparison to a normal, structural normal heart here in this patient with a normal rhythm. Unfortunately, is a progressive disease process, as we talked about. 1 out of 5 patients, or 20% of patients with atrial fibrillation, will progress to become persistent within a year. So obviously our goal is to maintain and restore normal rhythm for as much as possible, at least minimize the episodes of atrial fibrillation if all possible. With less episodes of AFib, there is increasing quality of life, decreased hospitalization, and even mortality in patients with atrial fibrillation. So here is a front view of a heart model. That's a human heart, if you will. And the pumping chambers in the front, the right ventricle and left ventricle. The right atrium is in as here, left atrium is in the back of the heart, shown in this other picture. Note that I'm pointing out here to 4 blood vessels at the back of the left atrium called pulmonary veins. These are veins draining from blood from the lungs with oxygen to be pumped out to the rest of the body. And here, as you see, this patient is in normal rhythm and goes into atrial fibrillation at this point. This is a human heart, dissected human heart, showing the right atrium, and here's our natural pacemaker we're born with, the sinus node. And the left atrium is here with the 4 pulmonary veins, as I shown on the model. Note that the pulmonary veins have some extension of muscle that extends into the veins to anchor and support these veins because they're very important for us. And in this case, going back, note that atrial fibrillation starts, and the reason I point out this pulmonary veins is this most often is the initial triggers arise from one of the 4 pulmonary veins. So as I mentioned to you before, drug treatment for AFib to restore the normal rhythm has not offered a great level of efficacy, and we have for a few decades now explored other means, including this heart cath-based procedure called the catheter ablation. So patients come to the procedures. There is no surgery or stitches. We assess the heart via blood vessels from the lower extremities, from the groin area, into the right atrium. And at this site where babies typically have a hole in the heart is a very thin tissue that we use to cross to the left side. As shown here, we have 2 catheters, the left side, and the veins seen from inside of the heart now. We cauterize with radio waves or freeze the heart around the opening of these veins as an intention to block conduction, electrical conduction from the veins, therefore suppressing the electrical firing that starts atrial fibrillation. So that's all great, but the FDA came back at one point and told us, so if this procedure is good, you have to compare it with conventional drug treatment to see if it shows some efficacy and safety, of course. So about 15 years ago, there was this multi-center trial that compared patients with atrial fibrillation, compared the treatment with ablation, and other groups of patients received conventional medications for AFib. And as you see here, patients that received ablation, they remained free of 80% of the patients approximately remained free of atrial fibrillation with ablation, but only 20% of the patients stayed in normal rhythm if they received the medication. So ever since this technique's been evolved to where we are today, here's an example of one of our patients. You have the CT scan of this patient. The left atrium showing the 4 vessels there, 4 veins, the right atrium on the right. And you see that there was a trigger for atrial fibrillation arising from this pulmonary vein starts the atrial fibrillation. And during this ablation, as you see here, you can see the atrial fibrillation organizes and goes back into normal rhythm. So techniques and the technology is evolved a lot. See here from the CT scan, we can have we call endoscopic view and observe as we do the ablation to the right structure of the heart. Unfortunately, again, atrial fibrillation progresses, as I mentioned to you, and the body builds up scar tissue in the left atrium. As you see here, this is one of our patients. Anything that's not purple is remodeling of the heart with scar tissue. And the more of this scar that you have, the more refractory it is to treatment. So we have to be fairly aggressive as far as maintenance of a normal rhythm for these patients with ablation beyond of the veins, as shown in this case. But importantly, regardless, we're able to maintain normal rhythm for our patients. It's very critical that we assess stroke prevention in very detail. Unfortunately, for this patient here, as you see, a clot dislodged from the heart during atrial fibrillation, travels up to the brain and block a blood vessel, leading to a stroke on this patient. So keep in mind that atrial fibrillation increased the risk of stroke by 5-fold at least, and about at least 75,000 patients a year have a stroke related to atrial fibrillation. And these strokes tends to be more severe. It's twice as likely for patients to become bedridden and increase mortality compared to other types of stroke. So important also is that stroke risk persisted even for patients that are asymptomatic during atrial fibrillation. So I'll move forward here with Dr. Philby that's going to discuss the strategies for stroke prevention at the university hospitals.
All right. Okay, here we go. We're still good. We had to play musical chairs for a second.
No problem. We can see you now.
Great. Okay. So as Dr. Ruda was saying that, one of the principal means of management for atrial fibrillation is for stroke prevention. And as it turns out, the majority of clots that cause stroke form in one section of the heart in the left atrial appendage. This is a little pouch-like projection from the left atrium where more than 90% of the blood clots that cause stroke form. This little pouch is often analogous to, often people say it's analogous to the appendix of your intestines. It serves really no clear biological purpose except for the fact that it forms blood clots in much the same way that the appendix serves no purpose in your intestines. And of course, you can get appendicitis and then have the appendix removed and live a perfectly normal life. Well, these left atrial appendages, these little pouches that originate from the left atrium, they can have a variety of different sizes and shapes, from a windsock to a chicken wing, a cactus and a cauliflower. All these bizarre morphologies or appearances can occur, and it's as unique to each individual as a thumbprint. Suffice it to say that the more complicated the appendage, the more likely it is to form blood clots. You could see in this cauliflower morphology, all these little nooks and crannies, all these little crevices are sites for blood to sort of settle in atrial fibrillation and form a clot that ultimately, if it transits the heart, can cause a stroke. And this is why, doctors like myself and Dr. Aruda will place patients on medications to prevent stroke, blood thinning medications. Warfarin, medications such as Eliquis or Xarelto, you may have heard. These are very popular, commonly used medications, but they also are very powerful. They thin the blood. They help to prevent stroke, but they are also a common cause for bleeding. So the number one reason for patients to be admitted to the hospital from a medication side effect or an adverse event is from one of these medications. both spontaneous bleeds, but also if you were subject to trauma, got into a car accident or fell off a ladder. That injury would be compounded, understandably, if you were on a blood thinner. You would have more serious injury. So the question is there an alternative to these medications to prevent stroke and atrial fibrillation? As it turns out, there are a number of procedures and devices, surgical procedures and device therapies, that what they do is basically exclude the left atrial appendage. We're basically blocking off or closing down this appendage. Keep in mind, if this is where the blood clots form, if we cap or close that off, those blood clots, if they form in the appendage, can then not exit the appendage, go into the heart, and therefore travel to the circulation. So there are two commercially available devices that are done with a minimally invasive technique. The Watchman Flex is one such device. The Amulet is another such device. We do both devices here at University Hospitals. Dr. Arruda and myself are the implanting physicians on our team. And as I said, they both work in the same way. So here you could see in these cartoon images, the device being implanted. This is the delivery system, these blue cable here, and it's inserted into the device by a screw-like insertion that ultimately gets released. And upon doing so, when it gets released, the body, the heart, grows tissue, what we call endothelialization. It literally is grows tissue over the face of the device, which has fabric associated. This device is made out of a very spongy, elastic metal frame that allows us to deliver it through a small tube, a catheter, what we call. And upon delivery, the face of the device, which has that fabric associated with it in both appliances, allows that promotes the body to grow tissue. And in so doing, becomes completely closed from the circulation from the rest of the heart. Again, so that if you form a clot here, it will not travel, it cannot. We have closed off the appendage for the rest of the circulation. So the question is that device, is this process, this procedure effective for reducing stroke? And this was shown in two important trials. And what they found is that in patients who were high risk of bleeding or had a reason to pursue an alternative to being on a blood thinner, and we'll talk about the indications, there was over a 40% reduction in death. Almost a third of those patients had a reduction in all-cause mortality, and there was an 80% reduction in hemorrhagic stroke. So in other words, what we're doing is we're preventing bleeding and offering a protection against ischemic stroke, which is the stroke caused by blood clot formation and traveling to the brain. So what are the indications for left atrial appendage closure? So these are patients who have indication they have atrial fibrillation, not due to mitral valve disease. They have atrial fibrillation, non-valvular atrial fibrillation, we say. And these are patients that have an indication to be put on a blood thinner, but have an appropriate reason to seek an alternative, a non-medication alternative. So patients who have a high risk of bleeding, okay? Patients who have a fall risk, okay? Patients who have had a previous bleed, patients who are treated with warfarin who have difficulty getting their INR levels, their ProTime levels regulated, patients who have issues with compliance, they forget to take their medications, or they don't take them in a reliable fashion, or patients who have lifestyle or occupational risk. So we've taken care of rock climbers, law enforcement personnel, and military personnel, people who could fall from high places or could experience trauma in the workplace that could lead to more injury than if they were not on a blood thinner medication. So is there an option for patients who are prescribed or recommended to be on a blood thinner medication and they seem to be tolerating that medication without any issues? What about patients who are not at high risk for bleeding? Okay, well, there is a study, a trial that Dr. Arruda and I are currently doing and University Hospitals. Is called the Champion AF trial, and it's randomizing 3,000 patients across the globe in a one-to-one fashion to either device or medical therapy to prevent stroke. So either an anticoagulant medication or a Watchman device, and following those patients for 5 years. So these are patients, again, who have atrial fibrillation, not due to mitral valve disease, but who can tolerate being on a blood thinner. So these are patients that are suitable for either approach. You can either be on the blood thinner presently, or you could have the first conversation with your physician or physician provider, whether or not you recommending you to be on a blood thinner to start. So these are patients with existing atrial fibrillation or newly diagnosed atrial fibrillation who are appropriate candidates to be on a blood thinner, but perhaps want to explore an alternative. You may be eligible for this trial. So the question is the appendage closure safe? And this was studied in this trial called the Pinnacle trial with the latest device for Watchman called the Watchman Flex device. And it showed really a very low rate of overall major complication. In this series of 400 patients, there was an overall major adverse event rate of 0.5%, and that was of ischemic stroke. I think as we have more patients treated with this device, and we have about 150,000 patients worldwide treated with Watchman, we think that risk is probably around 1%. So about 1 out of 100 for major complication. We would consider that to be low risk, 99% chance of no major complication. We've had an exponential growth of our program for left atrial appendage closure, university hospitals. And one of the reasons is because we've had a very high success rate. So overall, compared to national centers, this is a procedure that's quite successful. Most centers do a pretty good job. You can see the 2 bars on the left, university hospitals, we have nearly 100% success rate. And then devices per procedure, that's really a measure of how many times do you get it right in terms of choosing the right device. So if you choose one device and it doesn't work, then you have to go with a different device size. That gives you a number of devices used per procedure. You can see that here at our center, we're using just one device per case, which means that we do a very good job of picking the right device for the first time. And then also length of case. So how experienced and efficient are you in your center? How good is your team in deploying the device? You can see that we also fare better than national average when it comes to length of case. One of the reasons that we think that we've been so successful with our procedure is we've moved to a practice of using advanced cardiac imaging rather than a conventional approach, which is to use transesophageal echocardiogram. Now that's a big word, but what that means, if you've not had one of these procedures, is that an ultrasound probe gets inserted through your mouth and down your esophagus. And by virtue of that ultrasound probe going into the body, the cardiologist or the sonographer is able to get better pictures than they would if they were getting a surface echo. But still, if you can see here on the lower right panel, the images are still grayscale, black and white, and somewhat grainy. At university hospitals, we believe in using CTA imaging, which you can see in the lower right panel here, which gives you much more information, much more definition about the appendage and the associated heart structures that we are navigating around in order to do the procedure. And by comparison, these black and white images compared to perhaps a 3D reconstruction seem to pale in comparison. And we in fact have demonstrated that to be the case. So I'm going to take you through a left atrial appendage closure procedure so that you can see our workflow and how the procedure progresses. This procedure is done in the cath lab. So it's done with conscious sedation medications, what we call twilight anesthesia. So that you are able as a patient, breathing on your own, but you're able to answer questions, but you're kept comfortable. It's not painful. It's done with a sterile technique, and you're placed on a cardiac catheterization table here. And this is a picture of the lab in which we do many of our procedures. And you can see that the CT scanner is immediately adjacent to the cardiac catheterization table. This is the only arrangement of its kind in the world. And it allows for patients literally to go from the CT scanner, where we get valuable information in planning our procedure, to the cath lab table in sort of a same day protocol. And in fact, we do have a same day protocol, one-stop shopping. You come in, you get your CT scan. So we have good information, we huddle, We acquire the images that allow us to choose the right size device, and then we move you to the cardiac catheterization table, and you're home the same day. We start by taking the CT images and using those images in a number of different planes to take accurate, detailed measures of the left atrial appendage. And you can even see from the bottom right, we get a 3D reconstruction of the appendage so that we know how that device is going to be placed and interact in the other tissues of the heart. And that sort of information is just not available with a conventional approach. Here you see me standing holding a device. The device is about the size of a quarter, so it's quite small. If you can appreciate, the fabric is the white aspect of the device. Fabric sewn over an elastic metal frame. That frame is so elastic, it actually can be placed inside a delivery catheter, which is essentially a tube. So you see the device is actually in the end of this tube, and I'm preparing the device for deployment by aspirating and injecting water, saline water, through the system to make sure that there are no air bubbles. And again, this is as the device is placed into the appendage, it's associated or attached to a delivery system that then gets removed. And in so doing, then the tissue of the heart begins to accommodate, accept, and grow over the device to complete the closure. This is what Dr. Ruda and I see in the catheterization laboratory. These are images that are done with fluoroscopy and also with intracardiac echocardiogram. So we're using a variety of different images to perform this procedure. We use the CT for planning, and then in the context of the procedure, we're using real-time X-ray called fluoroscopy, as well as intracardiac echo. And that is different from the transesophageal echo. This echo probe is so small, it is actually threaded into a vein and placed in the heart. And it allows us to get very good images inside the heart, like a tiny periscope. Here, you might be able to appreciate the intracardiac echo probe next to the delivery system. And we take angiographic images of the appendage. These images can help you to understand how complicated these appendages can be with all these little nooks and crannies where blood clots can form. The panel on the right shows the device actually being deployed. I'm not sure if you can appreciate that, but the device is slowly being extended out of the delivery system, and it opens up like a flower or like an umbrella. Once the device is released into the appendage, we then take additional images using the intracardiac echo probe to make sure that there's no leak around the device. In other words, we're confirming through multiple criteria that the device has been well-sized, well-suited, well-situated, is in a good location, so that when we release the device, it will stay in a very stable position and effectively seal the appendage off. Here you can see in this right panel, the device having been released. This patient had a previous defibrillator, a pacemaker, so those are those leads there that you see. After the procedure, we put the patient at bed rest for 4 hours. We obtain a surface echocardiogram, a transthoracic echocardiogram, so on the chest wall surface, taking images of the heart. And then after 4 hours, most of our patients are discharged home. As a matter of fact, I just looked at the analysis for our last year. About 90% of our patients are discharged home on the same day, which is different from many centers. And again, largely attributable to the success that we have achieved from our center through experience and advanced imaging, as well as the use of conscious sedation, rather than putting the patient under general anesthesia and placing a breathing tube. We allow the patients to breathe on their own. So less sedation means faster recovery. Now, one of the questions that are commonly asked of us is whether or not patients have to continue their anticoagulant blood thinner after the procedure. There are two strategies for this. One strategy involves continuing the anticoagulant for 45 days, doing an imaging study, and here we do a CT scan, so a CT scan at 45 days. And if the device appears to be healing well, in a good location, doing its job essentially, then we would transition to aspirin and Plavix or clopidogrel, and that regimen is continued for 6 months. There's an alternative strategy, and that would be for aspirin and clopidogrel for 6 months immediately at the time of implant. In other words, you don't start or resume the anticoagulant medication. All right, so you get placed on aspirin and clopidogrel for 6 months. The CT scan is performed at 45 days, and then the aspirin and clopidogrel is continued for a 6-month course. This strategy, either strategy 1 or strategy 2, is individualized for the patient. And that's a decision that myself and Dr. Aruda would make in conjunction and speaking with the patient as well as their referring physician. But just to clarify, it does not necessarily obligate the patient to continue an anticoagulant medication. I've had patients, and Dr. Aruda as well, they've had intracranial bleeds, brain bleeds. And those patients, we would be very, very uncomfortable resuming anticoagulant medication. So we would probably choose strategy number 2. So just a few conclusion statements. As Dr. Aruda mentioned, atrial fibrillation is the most common heart rhythm disorder. It's associated with a 5-fold increased risk of stroke, a major cause of morbidity and mortality for patients in this country and worldwide. The rhythm can be managed with medications and effectively with procedures called catheter ablation. The stroke risk is reduced by anticoagulant medications. Of course, the problem is many people can't take these medications. Many seek an alternative to these anticoagulant medications. It's important to understand that what we're targeting with those blood thinner medications is the left atrial appendage. We're trying to prevent blood clot from forming in the heart, but really that left atrial appendage is the site where the vast majority of blood clots form. And the left atrial appendage closure procedure is a one-time procedure with a lifelong benefit in stroke risk reduction. This procedure is performed at university hospitals with advanced imaging and a same-day discharge protocol. So on behalf of myself and Dr. Aruda, I want to thank everybody for their time. We have this slide indicating Dr. Aruda's office locations and my own, and appointment contact information below. And we have saved questions to the end. We have a few minutes here. I'd be happy to entertain, and myself and Dr. Aruda, questions related to either part of the presentation.
Thank you. Thanks, Dr. Philby, and thank you, Dr. Aruda, as well. We do have some questions from the chat, and so I will kick this off and defer to you on who would like to discuss an answer to these. So the first question is around the intake of caffeine and alcohol related to AFib. So should the intake of caffeine and alcohol be limited or completely eliminated from the diet of a person who has been diagnosed with AFib?
I'll take that. So I would say that any potential stimulant to the heart should be cautiously used. Caffeine and even tea, as well as alcohol, can be a stimulant of the heart and increase the heart rate, particularly during AFib, and may even drop the blood pressure. So yes, I don't think it needs to be completely eliminated, but really pay cautious attention for the amount of caffeine intake and alcohol as well. So it's not mandatory elimination. Okay, and in regards to heart rate drops, actually, one individual was diagnosed with AFib last year and believes they may be over medicating. So mentioned that he's on Eliquis 5 milligrams 2 times a day and Metropol 100 milligrams 2 times a day. After taking the medication within 2 hours, the heart rate drops to 31 or 40. Wanting to know if it's normal to drop this low, and if not, if he should consult his physician again. Okay, well, the use of beta blocker to control the heart rate is important. And in the amount of the dosage of metoprolol or any other beta blocker needs to be adjusted based on the heart rate. Obviously, this patient is taking the dose, even though maybe low, is probably an overdose for this patient. Or there's also maybe other conduction problem and in the heart that should be seen by a cardiologist or one of us to assess if there is true need for a beta blocker for this patient. It may not be necessary.
Okay, thank you.
Mhm.
Let's see here. We have another question about medication. So has had AFib for over a year. It is on Xarelto, is having increased dizziness, gets out of breath quickly. Should he see a cardiologist again? He did have his heart stopped and shocked 2 times, but it did not work. Is it time to reach out to the doctor again?
Yes, it's particularly the electrophysiologist. I'll be glad to see the patient. The AFib has progressed to become persistent. It even failed the cardioversion, the shock. So I would say if there is if we should make an effort to restore normal rhythm, it's a patient that might be considered for ablation at this point.
Okay, thank you.
Mhm.
And can taking blood thinners cause bleeding of your internal organs?
Maurice was saying I can take this one because it's an easy one. Yes, it certainly can. You can have bleeding spontaneously in any organ. Most commonly, we see bleeding from the gastrointestinal system, but these medications are quite potent. They're very potent. They serve an important role in the management of many conditions. In this situation, we're talking about is stroke prevention, but they can certainly cause spontaneous bleeding. And what can be done about that? Well, you need to make sure that with your physician that you're on the right medication, that it's dosed appropriately. Some of these medications have levels that need to be regulated, such as warfarin. Some of these medications have to be dose reduced if you have kidney dysfunction. So I would speak with your physician if you have concerns, your prescribing physicians, to make sure that you're on the correct one and on the right dose. That being said, even then, if you're on the appropriate medication, we still see problems, which is why the left atrial appendage closure procedure has an important place in management for these patients.
Dr. Philby, there was another question about Watchman specifically. Can the procedure be used when a patient has a pacemaker or a stent?
Yes, we commonly, as you saw in the images that I showed you, we commonly have patients who have pacemaker leads or ICD leads, defibrillator leads. Those leads have to be carefully avoided, which we do. The device can be safely placed. A cardiac stent refers to a small metal alloy tube that's placed in the arteries that sit on top of the heart, which is in a different location altogether. And that would be of no concern to an implanting physician for the left atrial appendage closure procedure.
Okay, and this question is actually this next question is actually to Dr. Arruda. So this individual had ablation surgery in 2014 and was very successful, but sometimes still feel a flutter. Is that common? Can AFib come back after what's deemed a successful ablation?
Yes, it's depend on the level when the procedure was initially done, the type of AFib at the time, carry a risk 20 or even more, 20% or higher of requiring a second procedure. If there was a true surgical procedure versus a catheter ablation for this particular question, may have some implications. What would be the next procedure be? But yes, this patient needs to be seen, monitor for the burden. Maybe it's an intermittent process, maybe it's a flutter. So there's few aspects that we need to be seen before we consider a second ablation. But yes, definitely it's something that we 20% of patients end up going through.
Okay, so it sounds like that might be something for follow-up then as well, if they're experiencing that.
Yeah, absolutely, yes.
Okay. So there are a bunch of questions in here about preferences for blood thinners. I'm not sure if you have preferences on Xarelto, Eliquis, warfarin, something else, or if it's really just based on specific patient. Can you speak to that for a moment?
I haven't really prescribed anticoagulants in a while because my area of expertise is really with interventional cardiology. I don't think there is much difference between the entire family. There is some data with Eliquis being a little safer in terms of lower risk of bleeding than the other.
Lower risk of bleeding. So the first, the long-time used Coumadin, warfarin for AFib, is a very inexpensive medication and it's been there for many years, but is very difficult to manage. And overall, if all possible, patients should consider one of those new agents that are promptly effect. It goes away as soon as you stop it very quickly. They have antidotes also in an emergent situation. So preferable one of these new drugs, either Eliquis, Xarelto, or Pradaxa. They seem to offer good level of protection. The Eliquis seems to be more protected. There's some data that suggests that's a little bit better as far as bleeding risk goes. But remember, there are other criteria that patients have comorbidities that increase the bleeding risk. You know, some like kidney failure and other aspects. So that needs to be looked into as well. So yeah, that's generally speaking, that's the issue there.
Okay, thank you, Dr. Arruda. And would somebody then with all of these blood thinner questions be, is it appropriate to see a general cardiologist, or is that something where they should be scheduling with an electrophysiologist to discuss?
Most general cardiologists would be the prescribing physician for anticoagulant medications, navigating that choice, choosing the right one, following the patient. And then if that physician has challenges in managing the rhythm, so in this situation, the patient is there was a question that continues to be symptomatic. This would be an indication to refer that patient to a physician such as Dr. Arruda, an electrophysiologist, who is expert at managing the rhythm, helping to restore rhythm, or perhaps changing medications that might cause side effects.
Okay, thank you for that. Some more questions related to Watchman. I have systematic lupus. Could I still qualify for Watchman?
Yes. Lupus does not prohibit someone from having this procedure. So that's a yes, that the patient could have a Watchman device.
Okay, and what percentage of your interventions are ablation and what percentage are the Watchman? I mean, are these done in tandem? Is it one versus the other?
Well, this is one of these procedures that is shared in a family of cardiologists. I'm an interventional cardiologist, so I specialize in doing structural procedures of the heart, such as valve replacement, other devices to close holes in the heart and put stents in. But I also do left atrial appendage closure. Watchman is a specific device that is involved in left atrial appendage closure. And Dr. Arruda is an electrophysiologist. Now, he specializes in the management of heart rhythm disorders, both the medical and the procedural management, as well as the placement of pacemakers and defibrillators. And he is a Watchman implanter. We are the two members of the team for University Hospitals, and we share the procedure.
Yeah, I'll give you an example. I saw a patient yesterday that it was referred for an ablation procedure, but clearly meets criteria for Watchman implant, one of this occlusion of the appendages. So in patients like that, we stage it, we do the ablation procedure, and 6 to 8 weeks later, we place the Watchman. So it's hard to tell. You know, many of our patients coming for an ablation don't need the Watchman, and some of them already have a Watchman in place. They are not necessarily go together.
Okay, thank you. Thanks for explaining that. So Dr. Arruda, this individual recently underwent an ablation and they've been in AFib for a week now after the procedure. Should they be cardioverted?
Yes, well, first contact the operator who did the ablation to discuss that. There is, I preferably like to cardiovert the patient as soon as possible to let the heart heal post-ablation in normal rhythm. Some depend on the expectation early on in the ablation. The thought is that there's not going to be able to restore normal rhythm during this inflammatory phase post-procedure. They allow the patient to remain out of rhythm up to 3 months, and then at that point go for a cardioversion or a repeat ablation if needed. I don't support that approach. I like to, cardiovert patient as soon as possible.
Okay, thank you. And Dr. Philby, back to the left atrial appendage occlusion. Does the problem with the appendage exist with ventricle fibrillation as well?
Ventricular fibrillation is an entire different disorder. You know, when we say the word fibrillate, it means to quiver. And in atrial fibrillation, the top chambers of the heart, they quiver. It's supposed to appear like a bag of worms sort of quivering like this. As Dr. Arruda mentioned in his portion of the talk, the bottom chambers of the heart are the principal pumping chambers. So the atria are the receiving chambers. The valve opens, blood goes into the pumping chambers. The ventricles are the pumping chambers. Those ventricles then pump blood out of the heart. The right side of the heart, the right ventricle pumps to the lungs, and the left side of the heart pumps that oxygen-rich blood to the body. If you have fibrillation of the pumping chambers of the heart, called ventricular fibrillation, now that is a life-threatening situation that has to be managed with defibrillation. So we have to shock the heart, and we have to shock the heart soon. So that is the common cause of sudden cardiac death. So if you've heard of people that die suddenly or that are told to have sudden cardiac death, it's ventricular fibrillation. That is the bad actor. You can live with atrial fibrillation. You cannot live with ventricular fibrillation. So two completely different disorders.
Thanks for making that distinction. Another question, I realize we're coming up on time here, but if we could do a couple more. Can Watchman be done on a person with an iodine or IV dye allergy?
Yes, we have a contrast protocol, a contrast allergy protocol, whereby a patient is given certain medications, steroid medications, in advance of the procedure to safely mitigate any risk of having an allergic response. And we've done that and done it very safely.
Okay, thanks. And Dr. Arruda, what's the difference between AF and atrial tachycardia?
Like I mentioned, and I showed the slides, the atrial fibrillation is very chaotic rhythm. There is electrical activities in a very frequent, very often, very high rates, if you will. If you were to estimate the fibrillatory waves would be like 500, 600 beats per minute, while the atrial tachycardia will be a more organized rhythm that's faster than our normal rhythm, but it has typically one origin outside of the natural pacemaker that it takes over in various rates. It could be various different rates, but typically one source of electricity firing a little bit faster than a normal rhythm often can be a problem, depending on how fast it is. That requires also seeing one of the specialists in the rhythm and very likely undergone an ablation procedure for it.
Okay. Thank you both. I realize now we're at 1 o'clock. We do have more questions in the chat. We will take those offline and consider them for future sessions, or perhaps adding content on our blog. But at this time, I wanted to thank our presenters for your time and sharing the information today and answering the great questions that were sent in. And a couple final notes for the audience. We will email a link to view this session on our website once it's posted. And to schedule an appointment with either of our panelists or another member of our University Hospital's Harrington Heart and Vascular Institute team, please call 216-340-8709. And this concludes today's session. Thanks everybody for attending, and have a great afternoon.
Thank you for having us.